It's a new concept, but it has been devised with a lot of discussion with the people. Like we ourselves have earlier, when we were resident, we used to join these courses, and then our residents they also go. So we have discussed, and then the faculty who have been the faculty to kind of these courses. So what we have all one thing in common, we have observed that what happens is that when people go for the dissection course, they many a times it happens that it's not clear that what they are going to do, what they are going to see, and it like it becomes a futile effort going a long distance to do a bone, dissect a bone, and then come back and then do nothing. So we have kept it a very small group so that whatever we want to really pass on to a select group of people, like when we announced this course, the same night I think we got 40 plus CVs for the registration, and then we did sit together and did find out that okay, we are going to have these people this time for the course, and obviously we'll accommodate more people in the coming time when we'll be doing these courses. So the idea is that before all of you come here for a dissection, hands-on dissection, just hold, just. So the we will be briefly discussing with you all the briefly the anatomy of the ear as we go from outside, and that anatomy will be limited to what an otologist need to know. We are not going into the anatomy for the anatomist. We are not going into the anatomy for the pathologist. We'll be discussing briefly only about the areas which you need to know as an otologist, pure otologist or the basic otologist. So I think we have sent you that how these modules are designed, but I'll be just just a minute. So these are the modules which we'll be having every week. So this time we'll be discussing the surgical anatomy of the pinna, external artery canal, and tympanic membrane, and the surgical part. So this anatomy part will be taken by our faculty, Dr. Sheetal Kotgirwar, and for the ENT part, Dr. Monish from SMS is with us. Similarly, next time Dr. Vek from PGI Chandigarh will be there. So I think we have sent these modules to you people, and we have also suggested a few books. If and we will be really grateful if you can just read these topics from those books. So one book which we always refer to is Mirkotos, which is a very basic book for the basic understanding of the otology. To like if we are starting the otology practice, we should be thorough in that volume of the Mirkotos. And then for the references, you can go see the Shambo. Obviously, we all have read the Shambo. And then there are for the temporal bone dissection, there is this Mario Sana uh, book is there where they have given very beautifully the stepwise dissection of the temporal bone. So let us hope that you all be on this for for next month, so that when we meet in July the external auditory canal also. Let's see. We are looking forward.
Sure.
How is? Matlab, we have discussed it before. I think when we met in Bhubaneswar. And how do you think it's? Matlab, it's will be showing all those videos when they come here. Like when one
Right.
person is dissecting and there is a gap in between the time, then we'll be showing all those videos.
Okay.
So
Seems
for
good.
the
Yeah.
very basic surgeries, for all the basic surgeries, we want them to go. But we all should be enriched once we
Absolutely.
meet.
Good job. I think it's a very good thing to have a constant interaction. This would also make it, when they come to AIIMS Bhopal, they would not be as unknown to each other,
Yes.
and the interaction can be much more informal that way. So they won't really feel, many times when you go to a course, you don't ask questions because you feel that it may not be a very right thing to.
We'll answer that, and that's the way science grows. That's the way we all have grown.
Yeah, and I was just going through the various topics for the otology course. It's the best part is it is, what is the name of the book? You mentioned Mirko Toss, right?
Kotos, yes.
So Toss has various volumes, and it's one of the very good books which is available for otology. And so as Dr. Vikas was mentioning, yeah, Shambog is the major book which we all go through anyhow. But just a one step higher, if you really want the surgical part to come in, you need to refer to Toss at many places, and it's a wonderful book. And Vikas and I were together during our post graduation, and I remember those days when we used to have those, photostat copies available, and trying
Yes.
to go through those books. But do get hold of this book; it's actually important.
So we'll share that what exactly which book we are talking about, because Toss has written a number of books like on
Yeah.
osteoplasty and all. But what book we are talking about is the basic book on the mastoid surgery, and that's a wonderful book to start with. It gives you a very good handmade sketches of the all the procedures. So it gives you a very good orientation that what is what and where are those things. So we'll be sharing. We'll be. I think we have mailed you, but we'll mail you the full details of the book. Dr. Sheetal Utkal.
Is she using a Mac?
Okay, ठीक है. Then we'll start with Monish. I think.
Okay.
Yes.
Okay, so I'll just share my
So
presentation.
Monish, I think all of you know Dr. Monish,
I don't think so.
but the people, I think the residents who might not be knowing Monish. Monish is like is the most brightest star
Yeah.
among the most brightest star who have come out of AIMS, and is has
Is always a discharging year, and that's not something which your aim is. So even if you've done a very good mastoidectomy, you have the various talks coming on it, but at the end, if you do not create a good meatus, the whole surgery would go fail. So every hard work of drilling that temporal bone would fail simply because your meatus was not proper, right? So why do we need it? Let's look at it again. This is your normal external canal. The patient is, let's assume, lying down. This is your external ear. That's your canal. That's your area of the mastoid. Now, when you do a mastoidectomy, this would actually go off. You would drill canal down mastoidectomy. You drill all this area. If you do not do a proper meatoplasty, this is how it remains, right? So everything which is present out here would keep on getting accumulated here. It would not drain out on this part on its own. And that is what leads to recurrent infections. That is what would lead to some accumulation of debris, some anaerobic and aerobic bacteria growing, a recurrent discharge, so a big cavity problem, only because you have not done a proper meatoplasty. Vis-a-vis, if this would have been shortened like this and this flap would have gone somewhere here, it would have made your cavity smaller, and this cavity would have been a self-draining cavity, right? I hope I'm clear, right? And then it also allows you to have a look. If it is at present, if it's like something like this, you cannot in your office or your OPD have a look at this whole cavity. This would remain hidden, and the surveillance would therefore be poor. It would be very difficult to clean this again and again, and the patient would be dependent on you to come to you every 1 to 2 months to get it clean. So the whole purpose of a surgery is defied, right? So you need a good meatoplasty. Now, how big a meatoplasty? Right? I mentioned it should not be too small, it should not be too big. How big is dependent on the size of your cavity, right? If your cavity is this big, you would need this kind of a meatoplasty. If your cavity is really big, you need a bigger meatoplasty. So you need to actually individualize as per that person. And that is why nowadays we have procedures to decrease the size of cavity, even if you have created a big one, to remove the disease. And we would discuss these in the further talks which come in. So if you want a smaller meatoplasty, you need to reduce the size of your cavity. Even if the disease wanted it to be bigger, and reduce it by various flaps, etc., which you would be discussing. So it would actually depend on the size of your cavity as to how big a meatoplasty you need. Now there are various techniques of doing meatoplasties. However, the basic 6 steps remain the same. Let me just play this video if I can. Sorry. Right. Okay. So you see this video and then I'll describe the steps. So given incisions in the external auditory canal, given incisions over the pinna, we are elevating the flaps, we are elevating of the subcutaneous tissue over it, identifying the conchal cartilage and removing the conchal cartilage, right? Now these flaps can be of various types. What is important is look at the conchal cartilage. We remove the conchal cartilage from this area and we remove the conchal cartilage from the floor of EAC. Always remember that. Let me just play that again. You given an incision over the external auditory canal, over the part of pinna, then you can go post-oral if you want. Identify the conchal cartilage out here, right? Remove that. Remove the conchal cartilage again. You have elevated these flaps off, right? And then remove the conchal cartilage again from the floor of EAC, right? You see this because this is what actually causes a big hump in the floor and would again not allow the things to drain out. So remove the cartilage from 2 places and then you suture it so well so that no part of the cartilage remains exposed. You want to cover the cartilage very well so that you don't have any perichondritis or chondritis of this area happening. So suture it up with the skin flaps which you have created. Now let's come to step-by-step discussion of meatoplasty, right? You have 2 incisions usually. One is in this area, right? Now this is the area which between, that is the area where there is no cartilage, right? So this is the place where you want to give your incision. So you do not have any cartilage here, we all know that. Other is a very small incision which you may give right over the conchal cartilage, which would be somewhere here. So now you give this kind of incisions and now then you can proceed endoral or post-oral. My usual way is to go post-oral, right? And that is what we show in the, you deepen these incisions, right? You can actually use a cautery many a times to deepen this, it may bleed, or you can use a simple knife, that's your decision. But if you're using cautery, be careful not to touch the cartilage because that would give very bad pain later on and maybe even infection in the cartilage. So you don't want to touch the cartilage. Use it only in this area if you really want to use it. Now then you go post-oral. That's what I would usually do, and that's why these kind of figures I've chosen. And then you give an incision in this area and reduce that soft tissue in the post-auricular area, right? I'm shaving this off here, right? Use your forceps, use your scissors, you may even use cautery. Just shave off and debulk this tissue. And then you put in your finger in the external auditory canal, and you can see your finger out here. And then again debulk the remaining tissue right over the conchal cartilage, right? So you are removing this off, shaving this off, expose the conchal cartilage, right? That's your skin, that's your finger in the EAC, that's your EAC skin, that's your conchal cartilage, and you've debulked all the tissues over this cartilage, right? So you have removed the soft tissues, you have exposed the cartilage. Now this is what it would look like to you, right? Your finger is going in from this area, right, behind the pinna, actually anterior to the pinna. You are sitting here and you're seeing your finger coming out here in the external auditory canal. That's your cavity. You've removed the post-auricular tissues, you debulk those away and expose the conchal cartilage. Now, depending on the size of your cavity, if it's a small cavity, you remove just a sliver of the conchal cartilage. If it's a bigger cavity, you remove much more of the conchal cartilage, right? Expose it, this whole area, remove the cartilage. Take care that when you're removing this cartilage, that is cutting with the help of a knife, don't go till the skin. You need to preserve the skin. So just a partial thickness of the cartilage that you would probably cut, and then use blunt instrument, right? So if you are very good, very experienced, you may actually go till the level of skin, but there is always a risk of damaging the skin. So you don't want to damage the skin of EAC. You would just go partial thickness over the cartilage and then shave off this cartilage with the help of blunt instruments. Now this could be just a simple scissor or your freehose elevator, but preserve this skin, right? This is a very important skin to preserve, because later on you will be using this flap to cover your cavities or to cover the exposed cartilage out here. So you want to preserve the skin, and you remove off this piece of cartilage. So this goes off, and then you just put on sutures and then just see if this is an adequate meatoplasty for you or not. Just pull on these sutures and you can come to realize if you have created an adequate kind of a meatoplasty. That's really completes it. However, you need to look at the various flaps which are described in the literature and then decide what you want to use. I'll tell you what I usually use. And these are the various flaps which are described in the literature, right? Endoral approach, you have the corners flap, you have the surdale flap, and then you have the rarer flaps. Now, these are the two commonly used flaps. Then the Fagan, Gomez, Merck, Tong again described various flaps, but the most commonly used are these two. There are other flaps also described, but not very commonly followed. Post-oral approach, you can again have the corner. So corner can be end-oral or post-oral. With the Portman, the fish, the Stacke or the Pense flap, and Eisenman and Vormann. Now again, corner, Portman and Stacke are commonly used post-oral flaps, and the end-oral are corner, surdale. These are the common end-oral flaps. Don't be confused, right? There are too many names. You may not even know the name of what we are doing. It's good to know, but you need to know the basic concept and then just go about devising your own, maybe a mixture of all these, just to get a proper wide meatus, proper removal of the conchal cartilage from the floor as well as the simba area, and then good covering of the remaining cartilage, right? The basic thing is that. Now, just to make it easy, we divide these into these kind of things. I'll just be discussing these four main flaps. You can divide it Portman into two. So if you're mainly elevating a laterally based flap, it's corners flap. If you're mainly elevating a medially based flap, it's surdale flap. If you're basically elevating an inferiorly based, it's stack flap. And then if you do not want to remove the cartilage, a small flap can be Portman. A large flap of Portman would be removing a very big cartilage, right? So I will discuss all these five, and then I hope that you can understand what it's really about. And I'm going to use graphical images for that. So look at these two images, right? Now let's look at the first. Remember these names, right? And I'll be discussing this again. So if using a laterally based corners flap, right? How do you want to give an incision? you're looking end oral, right? And this is easier to explain, so that's why I'm going to use this figure much more commonly. Your first incision remains in this incisura, right? So this is where your incision comes in. So let's, for making it easy, just keep it like this in 2 dimensions. Second incision is somewhere here, the smaller incision, right? In the EAC, you've already given this incision, right? Now, if you have to elevate a laterally based flap, right? So the circumferential incision in the EAC would be nearer to the tympanic membrane. This would be something like this, right? I hope you can see those red lines. This is one incision, this is the second incision. Your circumferential incision comes like this. You elevate the flap till this, in this direction, right? If you're doing end oral, this is what you need to do. You expose your conchal cartilage, which is here, and then remove whatever part you want to remove, right? So it's basically simply doing this. This is what a corner's flap is, right? If you're doing post oral, your incisions would be something similar. You given one incision here, you given another incision here, right? And then you have given an incision here. You've already entered the canal, right? This is your entry into the canal, where you have already given an incision in the canal. Now just elevate the flap from here in this direction, expose the conchal cartilage which is present here, and then excise it off, and that takes care, right? That's your corner's flap, a laterally based corner's flap. And then you can actually just, when you've elevated it off, you can partly suture it with this part so that the exposed cartilage is gone, and you can place the rest of the flap out here, so you make the cavity smaller over the attic area or the tegmen area, and then you put it here, right? That's your corner's flap, right? Now, if you want to know what is serdile flap, that's a second, it's a medially based, right? We come to this medially based serdile flap. Nothing different. You give first incision here, you have your second incision here, the circumferential incision which you had used. Now the medially based flap which is there is the serdile flap. So if this was the corner's flap, this is the serdile flap, right? So the medially based flap is the serdile flap. Now obviously, for it to be functional, it cannot be very small. So there have been various modifications of the serdile flap. So if you give it bigger, that is you elevate it more laterally, you give it incision here. So this hole becomes a bigger flap. That's a bigger serdile flap. If you are dividing the serdile flap, this was your initial flap, you divide it into medial and you divide it into two halves. You give an incision again here. One flap will go here, the other will go here, right? And this would cover the smaller, the inferior and the superior parts of the cavity, and therefore this is again a serdile flap. So a medially based flap which you use for meatoplasty is the serdile flap. The laterally based flap is the corner's flap. It's basic and simple, right? So remember, what is medial is serdile, what is lateral is corner's flap, right? Then you come to the third, which is the inferiorly based Streck flap. And I use this very commonly, and I'll tell you the reason why I use it very commonly. The incision, how are they? This is superior part, right? This is the inferior part. So you have the first incision which you gave here. See, second incision may be here, you may not actually use it in this particular case. But what you do is, now you go very near to the tympanic membrane. So this is your incision. Then you give another incision which would be on the conchal cartilage like this. You would elevate the flap in this direction, right? Elevate it all off and expose the conchal cartilage present here and remove whatever part you want to remove. Now, why do I prefer this? It's basic flap, right? You have an inferiorly based flap. I prefer this because many a times the best area which I really want to, make my cavity smaller or to actually line it with some epithelium is the inferior part of the tip area. So that's the area which takes the maximum time to epithelize. So now this flap which I have created, I would actually rotate it here, and this would go somewhere like this in the mastoid cavity, right? So this would make my cavity a bit smaller, plus it would epithelize my tip area. Let's look at from the post-auricular point of view, because that's where we usually use it. So what I do is I give an incision in the incisura terminalis here, right? This is an incision which comes in. Then I would give an incision right here on the conchal cartilage. Okay, let me make it better. Right, this is an incision in incisura terminalis. The second incision comes here, right? There's an entry into the canal which I've already made, so this incision exists. Expose the conchal cartilage out here, remove that piece of conchal cartilage. Now this flap which I have created would go in here, right? So this would be kind of a flap which covers my tip area. So it epithelializes my tip area. It makes my cavity a bit smaller here. My meatoplasty is wide enough. I can make it as big as I want. So this is the whole area now then exposed by the big meatus which we have created. So this is the Strax flap, that is an inferiorly based flap, right? So again, before I go on to the next flap, you have three flaps: one laterally based cornus flap, two medially based surdile flap, right? And three is the inferiorly based Strax flap, right? You can use any of these flaps; they work out very well. Now, the fourth important flap is the Portman flap, right? So these are all of historical importance, but when you are doing a meatoplasty, it's always good to write down which flap you have used. Portman flap is nothing but a similar to a cornus flap kind of structure, but you go very near to the tympanic membrane, elevate it off, but you do not remove conchal cartilage. So it's Portman 3 flap, the small flap which you call, is without removing the conchal cartilage. So it's only for very small cavities. You would just suture this flap to cover the conchal cartilage and make this bigger, right? But it usually is inadequate if you have a bigger cavity. So a small Portman flap does not work out. The bigger Portman flap, that's called as the 5 flap meatoplasty, gives you a very big meatus. And if you have a very big cavity, that's what you would do. How do you do that? You give an incision something like this, and then you give an incision like this. So it's a Y-shaped incision. Now you elevate off the flaps from in these three directions, right? So what you ultimately get is when you elevate it off like this is something like this. So initially your this incision remains. You have given these two incisions and then you elevate it off. So it becomes kind of a big, kind of uh, structure like this. And when you've elevated these flaps, you elevate off these flaps here. So it becomes a structure like this again, right? So these incisions would kind of give you this kind of an exposure. So you have exposed the conchal cartilage out here. You can remove it as big as you want. So this whole cartilage goes off, and here the meatus is exposed, and you suture this off. So ultimately it all becomes like this, right? And this is the whole area. You can make it as big as you want. So this, now why do we call it 5 flap? We call this 5 flap because when you are elevating off these flaps, right, this becomes something like this. You have 5 flaps. What are these 5 flaps? This is the first flap. This is what we call as a conchal flap, right? You've elevated off this flap, that's a conchal flap. The second flap is this one. This is the inferior concho as well as the meatus. So inferior conchomeatal flap. The third flap is obviously superior conchomeatal flap. You have the fourth flap, which is the inferior meatal flap, and then the fifth flap here, which you elevated from here, is the superior meatal flap, right? So you have these 5 flaps: the conchal flap, inferior conchomeatal flap, superior conchomeatal flap, inferior meatal flap, and superior meatal flap. It's obvious, right? It's just, you don't need to really remember these names. It's obvious by the the area where they belong to, and therefore this gives you a very big exposure, and you can remove as much cartilage as you want and have a wide meatus. Important, there have been various articles, floor of the ear canal, right? So you have to remove this cartilage. That's what will give you biggest area of exposure, especially the inferior part. So this, remember, You will usually have some vessel running here, it would bleed. So be ready with your cautery. Use minimal and precise cautery so that you do not touch the cartilage a lot. And then remove this floor of EAC. It has to go off in all the meatoplasties which you do. Come to canalplasty now. Meatoplasty is the most important thing, right? Because you would do lot of canal down mastoids which may require this. Now canalplasty, as I said, it deals with the bony external auditory canal to achieve self-cleansing of any debris or cerumen collection. And if you're doing a plain tympanoplasty, you just want to post-operatively, you want to look at all the quadrants of the tympanic membrane very well. So you want to do a canalplasty. Now, usually issue with me is surgically when you have an anterior canal hump. It could be a minimal overhang, what you see something like this, but you see the perforation well, so it's not a big issue. It could be a moderate kind of an overhang when it covers partly the interior part, and you may actually need to drill on this. It could be a large overhang which covers your canal, and you cannot do a surgery at all without drilling on this. So what you do is you give an incision right over this hump. You give this similar kind of an incision in the anterior part. Elevate an anterior tympanomeatal flap, which we all know now. We keep on elevating of this flap, and then preserve this flap and drill onto this bone. Remove this bone completely and use some or the other thing. You can put some uh, suture material or anything to really preserve this flap, and so that it doesn't get into the drilling burr, right? And you preserve this with your suction, whatever you want to do. Drill off this bone, and then as I said, you can preserve, you can put any material out here so that the flap remains away from the your burr, right? You can actually use some silastic if you want, anything for that matter. And then you drill onto the bone, deposit the flap back, and you see the whole perforation, right? Need to do canalplasties many a times. You can even need to do it posteriorly. So I'm going to just show a video of the same, right? A French video, and this is, when you look at this, you cannot even see the perforation well. There's a posterior overhang. So what we do is elevate off this flap, right? And when you are done, do not elevate it completely to the middle ear. Stop lateral to the annulus, because you do not want your bone dust to enter the middle ear cavity a lot. So just cover again using the cotton ball just to hold on to your flap, right? I'm not going to the annulus, kept my cotton ball there. Now drilling from lateral to the medial, right? Don't go very medial initially. Drilling on the lateral part of this canal, widening it laterally, and then slowly going medially. I would individualize it again as per the requirement of that particular case as to how much bigger I want. Remember that when you are going medially, you have two issues. One, you may damage the canal flap, the tympanomeatal flap, or second, you may actually go too deep and damage the fascial. Remember, fascial can be lateral, fascial can be malformed rarely, so use very good irrigation and don't drill a lot when you are medial. Usually the fascial is not lateral to the annulus, so keeping the annulus intact would help you out, but inferiorly in this area, the fascial may come out laterally many times. So be careful when you're drilling in this area. Majority of time, almost always, you will not encounter fascial, but be careful and use good irrigation. So now I've elevated the flap again, gone more medial, reduced the size of my burr, and then started drilling again. So this is what you need to do. And then reposit the flap again and again if you are not sure, just to check the visualization which you are getting, right? Because you're going to do more work inferiorly, you have to drill inferiorly, but be careful, do it with good irrigation, and then just keep going till the level you can achieve a good visualization. Now once you are happy with it, then you can stop and proceed with your tympanoplastic procedure. Now you can do canalplasty for external auditory canal atresias, but that's not what the discussion in this particular topic today's talk was. So we're going to limit it for tympanoplasty to get a good visualizations. Elevate the flap. Do not elevate of the annulus. Go from lateral side and then keep going medially. Decrease the size of the burr. Keep on checking again and again how much do you really want it to be. And now look the exposure which you have got, right? Initially we could not even see the posterior part of the tympanic membrane, and now it's so well visible. So this is what a canalplasty is about. The third thing, and a very small part about it, conchal cartilage harvesting. Now we need to do it for reconstruction of the canal wall. We'll discuss this in the various topics which come in. Reconstruction of the attic, to do any kind of cartilage osteoclasties, and for rhinoplasty procedures. Now you can use an anterior approach, you can use a posterior approach. If you're using posterior approach, it's pretty similar to doing a meatoplasty, but the incision remains only on the conchal cartilage here. Elevate off this flap, remove the cartilage with the perichondrium so that it doesn't necrose off, and then you just suture it off here. So it's depending on how much cartilage you want, you can use it. Now if you're using it for rhinoplasty, many a times you would kind of go here. Anterior approach can be used. You can give an incision here, and elevate of the flap, you can give an incision here, expose the area of conchal cartilage and remove the cartilage from here. Again, your choice, your area of expertise, your patient, you decide. I would, majority of my patients, ear surgery, if I'm doing, this makes more sense because using the same incision. If you're doing a nasal surgery, you may use this kind of an incision if you want, or you can again go post-op. Now, tips to avoid cartilage necrosis: preserve the perichondrium at least on one side. Okay, that's important. To avoid perichondritis, avoid use of cautery. Don't touch cautery, as I mentioned earlier. Also, use good betadine wash before closure, and avoid very tight perichondrial closure. That would put lot of pressure on the cartilage inside, and that can again lead to pain and infection. Why conchal cartilage is not too thick? It's a very good cartilage. You can even make it thinner if you want. You have very large surface area and good concave shape, which you would many times use for your surgery for osteoplasties. And as I mentioned, it can be accessed through the same incision. So thank you everyone. I think let's just finish it off here, and go ahead with any questions, or if we have the talk on the basic
Yeah.
anatomy now, we can go ahead with that.
So Dr. Sheetal is with us now. So we'll first start
Perfect.
with the very basic anatomy, which around the area which you have already discussed, and then we'll take up the questions if there are any, and then I'll would like to add a few points,
Yeah.
few practical tips in the last. Dr. Sheetal, please, you may start.
Yeah. Yeah, yeah. Just a minute. Just a wait. Entire skin I have to do?
Yes, entire screen. Yes,
Yeah,
yes,
yeah.
yes, entire screen,
Yeah, I
please.
have to go to share screen, right?
Entire screen.
हाँ, ये शेयर स्क्रीन कैसे करूँ मैं?
Share screen, as you will touch the share screen, ना, it will
नहीं,
show.
शेयर ऑप्शन ही सिलेक्ट नहीं हो रहा है इसमें ना.
नहीं, सेलेक्ट हो जाएगा, आप उसमें एंटायर स्क्रीन कर लीजिए.
ओके.
मैम वो जो स्क्रीन बनी हुई आ रही है ना आपके, उस पे उसको आप सिंपली क्लिक करो. उस पे एक बार क्लिक करना पड़ेगा.
एंटायर स्क्रीन वाला ना?
हाँ, उस पे स्क्रीन बनी हुई है बीच में एक, उस स्क्रीन पे भी क्लिक.
अरे इसमें मुझे आज क्यों प्रॉब्लम हो रही है थोड़ी सी.
रुको मैं आपको
हाँ
बताता
जी, हाँ
हूँ.
जी.
हो गया मैम?
या.
We are seeing your screen.
Yeah, but how will he
अब
come the
आप
PPT?
उसको मिनिमाइज करके पीपीटी ओपन कर दिए. नहीं नहीं, स्टॉप नहीं.
नहीं नहीं नहीं, मिनिमाइज कर रही हूँ.
हाँ, ओपीटी. अब आप, हाँ, यस. We are seeing now. You will not be seeing yourself, but we are seeing.
Yeah. So should I start now?
Yeah. Please go to the full screen
Huh.
mode.
So sorry all of you, I am
Yeah.
some technical issues was there. So we'll start with just re-revising the anatomy. So we start with the pinna and the development of pinna. So we can see in this diagram. So the shape of the pinna and the parts of pinna are formed. They are formed by the mesenchymal collagens. They are formed in the form of tubercles, which call we as auricular hillocks. And there are two varieties of hillocks. Initially, the anterior one and the posterior one. So the anterior hillocks, they are derived from the mandibular side of the first branchial groove, and the posterior tubercles, they are coming from your hyvoid side. And these tubercles seen on each side of external auditory meatus, and the collagen and the fusion of these, they will form the different parts of pinna. So the first hillock will give rise to the tragus. This is the intrauterine embryo. You can see how the pinna look like in the intrauterine life, and this is the adult one. So second tubercle or the hillock gives to the crus. The third one gives to the helix. The fourth one gives to the antihelix. The fifth one gives to the antitragus. The sixth gives to the lower part of the helix and the lobule. Now, muscles of the pinna, as there are extrinsic and intrinsic muscles, but as in humans, the muscles are not much important. In the lower animals, they are important for changing of the shape and to see the sound waves or the vibration they come. But yes, there are three types or two types of muscles. As extrinsics are auricularis anterior, posterior, and the superior. These are some diagram in which we can see the posterior one, which are attached from the superior temporal line, and they are inserted on the pinna. Intrinsic muscles are there, but yes, we are not go in detailing with their origin and insertions, but they are named as helicus major, minor, tragicus, transverse auricularis, and oblique auricularis. So these are some muscles, and these are some views in which we can see the muscles of the pinna. Now, when we see the blood supply of pinna, in one word, they are coming from the branches of external carotid, and they are coming from the adjoining branches of the external carotid artery. So in this diagram, you can see the perforating branches coming from the anterior auricular artery, the maxillary, the superficial temporal, and this is the same auricle from the posterior aspect, in which you can see the perforating branch. So the nearby branch are the terminal branches of the superficial temporal and the maxillary artery. Through their branches, the whole pinna is taken care of. Nerve supply, the motor supply is from the temporal and the posterior auricular branch of the facial nerve. As all of you know, the whole face is motor is facial nerve. We learn in anatomy in the first year as the motor supply of the face is facial, and the sensory supply is from the different parts of the trigeminal nerve. So sensory supply is vagus, the auricular temporal, the greater auricular, and lesser petrosal. So in this diagram, you can see the helical portion is taken care. The motor part of this portion is taken care by the facial nerve, and the green one is showing the sensory as auriculotemporal and the vagus, and this is from the posterior view how the different care by the facial and the auriculotemporal and the vagus nerve. So there are some points as tragus and the tragal point. So the anterior part of the tragus is actually pointed anterior, inferior, and deep to the superficial surface of preauricular area. And its anterior end actually take on a blunty pointed shape on the medial aspect, which we call as a pointer. So there are some points or there are some surface landmarks to achieve, or around the ear there is a one important cranial nerve as the facial nerve, and this point is actually you can see in this diagram by the red arrow. The main trunk of the facial nerve is typically located medial and inferior to this tragal point, and these are the rest of the landmarks to find out the main trunk of the facial nerve as the external acoustic meatus, their junction, the mastoid process, the posterior belly of digastric, and transverse process of axis, which are shown by the different arrows. So these all surface landmarks are used to locate the main trunk of the facial nerve, which are useful for your surgeries in the ear and surrounding the pinna. These are some anomalies of the pinna. This is pointed cup ear, in which the pointed ear is an abnormal protruding ear like this. This is Stiles ear, characterized by the transverse crest from the antihelix. This is abnormal something. This is leading or lop ear, a folding over the helical rim or upper third of the ear like this. And this is a helical rim deformity in which the irregularities or the compression that may occur anywhere along the entire circumference of the pinna. So we are not going in detail. All of you know these are all congenital anomalies. These are again some common ear deformities as conchal crus, in which an abnormal fold of cartilage crossing the mid portion of the concha simba that appears divide the ear as into two half. This is the abnormal crus. Then this is cryptotia. The ear cartilage framework appears buried beneath the skin with no apparent sulcus. This is mixed deformity, a combination of multiple deformities in the ear. The child in the photo above the cup ear, helical rim deformity and conchal crus. Now, when we proceed to the external acoustic meatus, as it is very important surgically also, so development wise it is developed from the 3 months of intrauterine life. And in the diagram, these are the routine anatomy diagram in which the blue color is depicting the ectoderm, the pink is the mesoderm, and the yellow color is depicting the endoderm. And this is the area where the first pharyngeal pouch grew and the cleft develops from the first pharyngeal cleft. Ectodermal cells at the bottom, they proliferate. You can see how it is changing the ectoderm, and here the cells proliferate to form the metal plug. And now in successive months, this dissolve to form the internal part of the external acoustic meatus. Now tympanic membrane, now you can see that when, in the next slides we can again revise why the tympanic membrane has the 3 different layers and how they are coming from 3 different germ layer of the body. In the external acoustic meatus, as it is important to remove the foreign body and different procedures for the surgical point of view, what is the actually whether that external acoustic meatus is straight or it is oblique. So it is 24 millimeter in length almost. The cartilaginous portion is 8 millimeter and the bony portion is 16 millimeter, which is not the cartilage portions. Posterior superiorly it is covered by the fibrous tissue, and the bony part is actually hidden in between the tympanic plate of temporal bone and the squamous part of temporal bone. It is not straight, it is S shape. You can see the S shaped here. So during the otoscopy, during the routine examination, foreign body or the wax removal or some surgical procedure or normal infections, so you have to like pull the to make that external auditory meatus or external acoustic meatus straight, and to see the clear vision you have to do the upward, backward and medially pull the pinna. So bony part meatus is absent in newborn, and the tympanic membrane that is supposed to be nearer the surface much more oblique than the adults, and that's why it is it should be handled in newborn very sensitively and slowly. The skin of bony part is thin and tightly adherent to the periosteum in bony portion. There are 2 important angles or the constriction in case of external acoustic meatus. One is at the junction of these 2, that is the cartilaginous portion and the bony portion, and one is the isthmus, which has surgical some importance as it lies 2 centimeter deep to the concha. Now sutures which are related with the external acoustic meatus, one is the tympanomastoid suture. In this diagram you can see beautifully in between this is the external acoustic meatus, this is the posterior border, and this is the mastoid process, and this is the tympanomastoid fissure or suture. The importance radiological, it can mimic or it can confuse with the pseudo. It has surgical importance as use palpable landmark to localize the facial nerve trunk during the parodectomy or repair of different facial trauma. Now there is a one more fissure which related with this external acoustic meatus as fissure sanatorina or Huschke, which is vertical fissures in between the portion of external auditory canal cartilage in the region of bony and the cartilaginous portion. So below this there is your parotid gland. So I think some infections can go through this fissure into the parotid gland also, or there can be a infection in the parotid gland. Now blood supply of external acoustic meatus is again through the different branches of the external carotid artery, through the posterior auricular branch, through the superficial temporal, through the occipital, and definitely through the maxillary artery. The nerve which are taking care of external acoustic meatus are the anterior and the roof portion is taken care by auriculotemporal nerve, and posterior wall and the floor are taken care by the auricular branch of vagus. Now, tympanic membrane, as we can revise as in quickly, it developed from the three portion: ectoderm, the mesoderm, and the endoderm. So, cuticular layer is its layers, the cuticle layer, which is the skin, which is continuation with the external acoustic meatus. The ectoderm, it is derived. Intermediate layer derived from the mesoderm or the surrounding branches, arches, and the mucosal layer is derived from the endoderm of the tubotympanic recess. So when the color of tympanic membrane is purely gray and semi-transparent, and the diameter is 8 to 10 millimeter. If you see the position, it is obliquely placed almost 55-degree with the floor of external acoustic meatus. In newborn, it is almost horizontal, and that's why we say like newborn, they can withstand or they can hear the noisy sound more. The malleolar fold divides the membrane into two parts, as it is the malleolus. Right, this is the handle of malleolus, and this is head of the malleolus, the portion of incus, and the third portion as the your stapes. And now these two malleolar fold divide the whole tympanic membrane into two parts at the pars flaccida and the pars tensa. So these are the two ways how the whole tympanic membrane are divided. And surface of the membrane, the lateral surface is more concave, which your external acoustic meatus, and the convexity is towards the middle ear. And then the anterior wall and the floor are longer than the posterior wall and the roof. The maximum point of convexity of this tympanic membrane is called umbo, and this surface also receives the attachment of handle of malleus. And because of the handle of malleus, this is the cone of light, and this is the way how the whole tympanic membrane is divided into different quadrants. So this is superior, posterior, anterior, superior, posterior inferior, and antero inferior. So this is the way a line which is drawn from the handle of malleolus and a perpendicular line through the umbo, which divides this four portion. And this is the way how the antero inferior quadrant has got cone of light. So this is again the same. We already see that this is the cuticular layer, this is the fibrous layer, and this is the mucosal layer. So blood supply of the tympanic membrane are coming mainly from the branches from the maxillary artery in the form of deep auricular and anterior tympanic, and branch from the posterior auricular also. And when you see the nerve supply of these layers, so cuticular layer is taken care by the auriculotemporal nerve and vagus, auricular branch of vagus, and mucosal layer is taken through the tympanic plexus. A word about the cone of light: it is nothing but a light reflex when which occurs when upon the examination of tympanic membrane with the otoscope. The shining light on the tympanic membrane causes a cone-shaped reflection of light which appear in the antero-inferior quadrant. This correspond at the 4 to 5 o'clock position, and in 7 to 8 o'clock position in the left eardrum. The apex of the cone is a depressed part of the tympanic membrane, which at the level of umbo. So this is the pictures of the otoscope through which we can see the cone of light. Now, external surface, there is a one more importance of notch of Reneus or tympanic sulcus. So in this diagram at the number of 9, so it is the notch of Reneus, and it is nothing but a small defect in the posterior edge of the bony part of annular tympanic ring. The defect is located just superior to the tympanomastoid suture. So this is mastoid process, this is external acoustic meatus, this is tympanomastoid suture, and this is the notch. The importance is chorda tympani nerve is also there, and yes, this the neck of malleus occupies this notch, and often it is met of your tympanomeatal flap. So there is a last word about the new diagnosis for the hearing loss. One of the diagnoses currently used is vibratory pattern of tympanic membrane. So nowadays, a most desirable test for hearing loss is measuring the direct movement of tympanic membrane. The test gives information regarding the functional status of tympanic membrane and definitely the middle ear and inner ear. So this is the recent Hamra et al. Demonstrated non-invasive functional imaging of human tympanic membrane under various acoustic excitation and identify a unique vibration pattern that may vary between human subject, and that could be one of the reason to diagnose the hearing loss. So I am ending with this basic anatomy. So thank you so
Uh,
much.
thank you, Dr. Sheetal. Thank you very much. So we have
Yes.
completed this first module where we have learnt about, or we have just reviewed the anatomy.
Yeah.
And I must tell you that to all the delegates who have joined, that it's not like that we need not to remember that how is the TM is supplied, how the periphery of the annulus is supplied, how the EM is supplied, or the canal is supplied. Because as you grow in your practice, it's not that you'll always be doing only the tympanoplasties where you will be putting a temporal fascia graft. You will also be encountering the other pathologies like, for example, if you, even if you are in your early practice and you encounter an early glomus tympanicum, you can do it. One can do it. So for when you encounter these kind of cases, there you would have to again important the anatomy is that, because you'll have to recollect that how, okay, if I'm seeing a vascular tumor in the tympanic cavity, so from where all it will be getting its supply. So what should be my approach, which part I should first touch, or from where I should start my dissection. So whatever we do at anatomy is something which always remains important, and we always need to keep on recollecting the things as we are into the surgical practice. So I'll just share my thought on what about the Monish has already told, that metoplasty is a very, very, very important thing, and we would try that all of you or most of you get your hands on with the metoplasty part also. We are hoping that we'll be getting the soft cadavers itself, where you can do the metoplasty part, you can learn the metoplasty part, you can practice the metoplasty part. Because in a canal wall down, like it's 30% is the role is of metoplasty. Whatever you have done to the bone, whatever you have done to the middle ear, if you're and if there is a big cavity and your metoplasty is not up to the size, your life and your patient's life will always be in trouble, and they'll keep on coming more frequently. Like canal wall down, we all know that they will be coming to us, say in 4 6 months. But if it is a it's less than optimum metoplasty, they'll be coming more frequently. And the most bad part is that many a time they do not come to you, they go to someone else. So that's the worst part actually. Another thing is about the canal plasty. Canal plasty is like, initially you might be whether if you are doing a tympanoplasty, most of your tympanoplasty through the post-oral route, you would you would think of that I really do not need myotoplasty, and that is what many of us in our early initial years we always think, oh, canal plastic की तो जरूरत नहीं है. I am able to put my graft in almost all the cases without doing canal plastic. That is what we think in our early years of practice. And one important thing is that, because what happens is when a patient fails, when a tympanoplasty fails, it is not that the patient is coming to us. That is the worst part. So if they do not come to us, we do not see our failures. But I bet that if you keep a close watch on your failures, you would realize that half of your fellows would be in the cases where during the surgery you could not see all the quadrants of the annulus. So what happens is that when a mentoplasty fails, we always tell, okay, this is something which has got contribution from everyone. There is surgeon's contribution, there is ECS contribution. The patient may be allergic. The patient might have gone to some water park. The patient had URI but could not take the prompt treatment. But the really these are the things which are important to improve your results. So whenever you see your failure, most importantly your failure, because in your cases you know that everything went well during the surgery, and then why this failure is. So always assess these patients with an eye on your canal, and you would find that yes, this was the case where I could not see the annulus in full, and then these are the cases when you are taking it them when you are taking them for a revision surgery, please do a canalplasty. Do a canalplasty. And when you are doing canalplasty, your aim should be that your drilling should that you create a cone. You create a cone. So use a biggest optimal size burr, preferably a diamond burr when you are laterally. Bigger size I'm saying because when you keep on drilling and if you're using a small burr, it might be that you have drilled enough and in the next sweep you will go inside the mastoid. The biggest possible size burr, and as you go medially, then you change your burrs, and then you should have a very good control on your hand. Otherwise, you may hit the your ossicles. So canalplasty is required in those cases. Please consider canalplasty in cases where you are planning to tug in your graft anteriorly. So they themselves are the indication for canalplasty where you think that okay, I have seen this case and during surgery I will do is that there is some anterior canal overhang and I will tug in the graft anteriorly. So please adopt a single way to do the tympanoplasty in most of your cases. See the annulus properly, all the quadrants, and adopt a single way to do it. If you are seeing all the quadrants, most likely, and you are putting your graft fresh, you are using a temporalis fascia, your results will improve dramatically. So if you people have any in, or if anytime later on we have a group now, then you can post your queries in the group, or you can mail us on the group on the courses mail ID, and we'll be happy to, and if there are cases which you want to discuss, or we'll be happy to discuss those cases. We want all of you who have joined this course to excel in otology. We, so these are the basic things which we'll be discussing. We'll be trying to show the basic surgeries also during the course or when you come here. So please feel free. Whatever doubt you have, please feel free to ask. That will improve yourself. That will help us also to improve. So that's I think Monish. So is there any query or question or suggestion from the delegates?
The Portman 5 flap thing. Okay. You want me to present it again?
Please do it and then we'll finish off.
Okay, कौन सा था? This would be fine. Okay, so Portman 5 flap, right? It's one of the biggest myoplasties. If you want, you can actually make by that technique. So that's a very good technique if you're looking for a very big cavity to handle, right? Now, what you do in that is you give an incision which is Y shape. So something like this. You give an incision like this here. Then this incision becomes like this. So yeah, and you elevate the flap in this direction, you elevate the flap in this direction, and you elevate the flap in this direction. Okay, so once you elevate these flaps, now this becomes something like this, right? This was your incision. Now once you have elevated it off, this becomes something like यहाँ पे ऐसा खुल जाता है वो, ठीक है ना? So it will open it up. तो ये पूरा area expose हो जाएगा. This can be as big as you want. You can use पूरा concha cartilage जो है conchal cartilage. This gets exposed here. You elevated these flaps like this. तो ये पूरा एरिया एक्सपोज हो जाता है. यहाँ पे हमने फ्लैप एलिवेट कर दिए तो ये भी फिर ऐसे एक्सपोज हो जाता है एरिया, ठीक है. सो यू गेट दीज काइंड ऑफ एलिवेशंस एंड एक्सपोजर. नाउ यू कैन एक्चुअली एक्साइज दिस कार्टिलेज फ्रॉम हियर. ये पूरा कॉन्कल कार्टिलेज यू कैन एक्साइज एज मच एज यू वांट. And now why we call these as 5 flap thing is because if you manage, this is your first flap, this is the conchal flap, this is your second flap which is the inferior conchomeatal flap, the third flap is the superior conchomeatal flap, the fourth flap is the inferior meatal flap, and the fifth flap is the superior meatal flap, right? It makes common sense. ये conchal flap है, this is inferior conchomeatal flap, this is superior conchomeatal flap, this is the inferior meatal, this is the superior meatal. So 5 flaps gives a very big exposure. You can remove this cartilage as much as you want from here and make a very big myoplasty, right? So that's your. I hope it's clearer now, right? Okay. Perfect. Right.
Thank you, Dr. Seetal. Thank you. Thank you, Monish.
Thanks, Vikas.
Thank you, Dr. Vikas. Thank you, Dr. Manish.
Thank you.
Sorry for the technical issues.
No.
I enjoyed your clinical aspect of here because we don't teach that much detail in first year students now. So I also enjoyed during the
Same
journey
here.
of this small PPT.
Same here. I also liked it. Thank you.
Thank you so much.
So shall we end, please? I think no more questions. Ototkal, please. Any suggestions? Any suggestions to further improve it? Okay then.
Thank you so much.
Hello. Good night. Good night.
Yeah.
Good night, everyone.